Hey, good evening, everybody, and welcome to this month's OrthoCarolina live webinar. I'm Dr. Jonathan Riboh, one of the sports medicine surgeons here at OrthoCarolina. In particular, I am a pediatric and adult knee surgeon.
And I'm Dana Piasecki. I'm one of Dr. Riboh's partners here at the Sports Center and also specialize in complex knee ligament reconstruction.
Just a reminder that a replay of this will be available on all of our socials for anybody who's not able to make it live tonight. Feel free to leave any questions that you have through our socials, and we'll take care to answer those at the end of the presentations. Without further ado, Dr. Piasecki and I tonight are going to have maybe a little bit of a debate about different ways that we can treat ACL injuries. One thing that I think a lot of people don't realize is that there's many different variations of how we can treat these surgically that have implications on how patients do. And a lot of this, we're still learning the right answers. And so it's really important to have these dialogues and engage our patients in these dialogues. So we hope you'll learn from this tonight. One of the hardest things we ever have to face as knee surgeons is a re-injury. So someone in whom we fixed, we feel like we've done a great surgery, they've rehabbed hard, they've done everything right, and they get hurt again. And sometimes some of our patients, this happens on live television, and this can be really, really a difficult situation for everybody involved. And from that comes a desire to always try to minimize the risk of re-injury after an ACL surgery. And I would start by saying, based on not just my experience, but what's out there in the literature, there's a problem with the current state of ACL reconstruction. I think if you asked most people, most patients, what they expect after ACL reconstruction, they expect their knee to be fixed and they expect to not have problems with it afterwards. Unfortunately, that's fairly different from the reality. If we look at young athletes, basically under 25 years of age, who return to sport, the risk of a second ACL tear is somewhere between 20 and 25%, which is much higher than many people realize. And part of the problem is not only is it devastating to the athlete to have another injury, but when you have a second ACL tear, there's usually more collateral damage. There's at least twice the incidence of tears to the cartilage called the meniscus, like a cushion between the bones, as well as a higher incidence of cartilage damage to the cartilage that lines the bones, what we call articular cartilage. And we don't have great solutions for these, so we really want to try to avoid those. Not only that, but the outcomes of a second time or a third time or a fourth time ACL, what we'll call a revision ACL surgery, are unequivocally worse. If you look at reviews, looking at all the studies that are available, unequivocally, these reviews show that the results at 5 years are consistently worse with a revision ACL surgery than with your first time. So my goal with every patient is to try to make it so that we only have to do this surgery once. Part of our challenge is that an ACL tear is rarely just an ACL tear. Many of you have probably seen videos of high-level athletes injuring their knee, and when you look at it, it's somewhat of a gruesome event. There's a lot of energy imparted to the knee. And when we really kind of dive deep on this, we realize that there are high levels of associated injuries. Without boring you here, you can see that some of these, like the medial meniscus, is injured 57% of the time that you tear your ACL. The MCL, one of the other big ligaments in the knee, is injured 41% of the time. The lateral meniscus, 25% of the time. So really, we're dealing with complex injuries that go beyond just the ACL tear. And the problem with this is that the more things you hurt, the more unstable your knee becomes. And so it's almost like a point or a strike system where you can have 1, 2, 3, 4, 5 knocks against the stability of your knee. And it can be really difficult to restore the knee to normal stability by just fixing the ACL. In fact, if we look at studies that have been done in the biomechanics lab, they show that doing an ACL reconstruction alone does not restore knee biomechanics back to normal. In particular, if you've injured your ACL and the outside, what's called the lateral side of the knee, an isolated ACL reconstruction leaves significant residual instability, both front to back as well as rotationally, neither of which are good for the patient. Well, our anatomy can help us in these situations. There is a structure on the outer part of the knee that many people have not heard of that's called the anterolateral ligament, or the ALL. This is just a cadaveric dissection showing that, and it runs on the outer side of your knee. What this does is this provides both front to back as well as rotational stability to the knee, and it's often injured at the time of an ACL tear. This ligament has actually been known about for a long time, but was rediscovered or basically written about more just about 10 years ago. And with that came a renewed interest in whether we might need to do something about injury to this ligament to help people who are having ACL surgery. If we look back at the history, I'm French originally, so I take a lot of pride in the French surgical history. These are anatomic drawings from the 1800s showing that they had knowledge of this anterolateral ligament all the way back then. Well, in the last 10 years, we've taken this anatomic knowledge, and what we've done is we've devised as a profession a new group of operations, and we'll call these extraarticular augmentation procedures, or LEAPs. And it's been shown that these really can reduce the incidence of an ACL graft tear, meaning tearing your surgical knee. The biggest of all of these studies was done in Canada by Dr. Alan Getgood, shown here. This is a very large study, had 620 patients just about, and it really is the gold standard study design, what we call a randomized controlled trial, meaning neither the patients nor the doctors got to decide which treatment. The patients were randomized through the study, which avoids any bias. And what this showed is that if we add an anterolateral augmentation, you get about a 4% failure rate. If you don't add that, you have about an 11% failure rate. And I think most patients would want to be in that 4% group. Additionally, if you look at who has some laxity left in their knee after surgery, again, you do but better at about 25% when you add a lateral procedure versus 40% with an isolated ACL surgery. Another study out of France, this is Bertrand Saint-Lécoté. He's a famous French knee surgeon. In fact, he's the busiest knee surgeon in the world. Does about 600 ACL surgeries a year, so we have a lot to learn from someone like this. He looked at over 2,000 patients that he had operated on, and he found that if he did just an isolated ACL reconstruction, as opposed to also fixing the anterolateral ligament, his failure rate was 3.5 times higher, with about a 20% reoperation rate with just the ACL and an 8% reoperation rate with the combined surgery. This has a particularly large impact in the patients that I treat. Probably the average age of an ACL patient in my office is 13 or 14 years old. And as you can imagine, these are kids that are going to go back to high levels of activity and really put their knees to the test. And so naturally, kids have higher failure rates than adults with ACL surgery. So if we can make an impact there, it's huge. And here in this study, again, out of France, adding a lateral augmentation gave you a 6 times lower failure rate than just doing the ACL. 2% failure rate versus 13%. These are really, really dramatic numbers. Interestingly, it matters in everybody, though. It may be a little bit more powerful of an effect in kids, but even in patients over the age of 30 years, you still have a 3.5 times higher failure rate if you do just the ACL surgery. Interestingly, these results also hold true in the revision setting. So we can do this anterolateral ligament surgery even in the setting of a revision, and it improves essentially all the outcomes we care about: patient satisfaction scores, rotational stability, front to back stability, what we'll call translational stability, as well as graft failure rates. And what's interesting about these lateral procedures is not only do they protect your ACL, but they also protect that specialized cartilage called the meniscus. So if we have to repair the meniscus, we want to make sure that it heals, and you're 2.5 times more likely to heal that if you have the anterolateral surgery than if you do not. And some people, like Dana Piasecki, might ask, well, do these lateral procedures increase the complication rate? It's more surgery. Surely there's got to be more problems with this. And that's a really valid and important question. Based on the studies that are out there, this has been looked at. And in the large study out of Canada, there was no difference when you added a lateral procedure in the incidence of minor adverse events, minor surgical events, or the overall reoperation rate, which is really reassuring. Another study, just about 400 patients, showed no difference in complication rates when adding this procedure. And finally, we've also looked at whether adding this procedure can cause the knee to be too tight. And you can imagine if something gets too tight, it can cause wear of the cartilage surfaces. But at least in the studies that are available, there's no difference in your cartilage health 2 years after the surgery when you add a lateral procedure. This is actually a study that we're doing here at OrthoCarolina that's about to be published, We're looking at my own patients at 6 and 9 months after surgery. I compared all of the patients, you can see in the black here, who had a combined procedure with an ACL reconstruction and a lateral augmentation, and those patients in the gray who had an isolated surgery. What you may be thinking is all of these graphs look exactly the same, and that's actually the point, is that there was no measurable difference in any of the return to sport testing, whether that was hop testing, strength testing, balance testing. We couldn't tell any difference between the patients who had the lateral procedure versus those who did not, essentially showing that there was no detrimental effect on your ability to return to sport. In fact, it actually looks like having a lateral procedure will increase your ability to return to sport. So in a large congregation of studies, what we call a meta-analysis, when you take multiple studies and you aggregate all of their results, it's been shown that you're 41% more likely to return to sports if you have a lateral procedure in addition to your ACL reconstruction, instead of just having the ACL reconstruction alone. And many of us think that's because the knee just feels more stable and you trust it more. As we look at larger studies out there, again, these meta-analyses, overwhelmingly, I feel like they favor these lateral procedures. They improve your clinical outcomes, you have better stability of the knee, lower graft failure rates, and like we talked about, you have a higher ability to return to sport. So in summary, if we look at patients who have torn their ACL, who are going back to competitive activities, adding a lateral procedure can help you have a more stable knee, a lower graft failure rate, lower meniscal re-tear rates, and a higher return to sport. The counterpart, as you see here on the slide, is that if you do just an isolated ACL, you can expect lesser outcomes, a less stable knee, more graft failures, more meniscus re-injuries, and a lower return to sport. Now, that may seem like a fairly biased view, and I will say I fall heavily on one side of this debate, but in all seriousness, I do think that these lateral procedures offer a lot of promise, but it's important to discuss the shortcomings. One is that by making the knee more stable, you always carry the risk of increasing stiffness. Stability and stiffness are the same end of one spectrum. And I will say that we have noticed slight increases in stiffness rates with this operation. The good news is that usually we can treat that pretty readily with either good physical therapy or occasionally a small procedure to remove scar tissue. When it comes to over-constraint of the knee, there are some laboratory studies suggesting this may be an issue, but even long-term radiographic studies show that this does not lead to arthritis. Because we've only been doing these lateral procedures for probably 10 to 15 years, we still don't have long-term outcomes. Meaning I can't tell you what happens if you do this and what happens 20, 30, 40 years later because the data is not available yet. And probably the biggest challenge is we know that these lateral procedures help lots of patients, but we don't know who can get away without it and who definitely needs it. Certainly anybody who we consider high risk, we think needs them, but this is something we're actively studying at OrthoCarolina with the help of our OrthoCarolina Research Institute, and something we hope to have better answers for our patients in the future. And certainly debates like this are how we all get better as a profession, so we thank you for taking the time to participate with us. And with that, I'll hand it over to Dr. Piasecki.
All right, thanks, Jonathan. So I'm going to give a different perspective. I'm going to give the perspective from the other side of it. So a couple principles I'm going to start off by just sort of outlining here. The first is that I completely agree with Dr. Riboh. Debate is really good for patient outcomes. We do not always know exactly what the right path is, and medicine is it's a very varied landscape, and we have to often find our way together. We also, I would tell you, having debate, I think, sends the message that we don't necessarily agree on something. Dr. Riboh and I both have very similar perspectives when it comes to 99.9% of the care that we provide our patients. And I think seeing a different perspective here really just highlights that we're paying attention to different aspects of the same thing. And I think you'll see that in his presentation. I hope you see it in mine as well. A second principle I would have that guides me here, though, is that I've been practicing now for 18 years, and surgery, and I know Dr. Riboh agrees with me here, as does everybody at OrthoCarolina, but surgery is a really big deal. And new recommendations for surgical treatment require very thorough vetting, which is, I think, a lot of what he was just explaining to you. My argument against LEAP procedures, or my bias, which is a little bit towards doing them less frequently, is that the way that these procedures were adopted skipped a lot of that vetting. So I'm going to go through that with you in a second. I actually agree with Dr. Riboh that the data supports use of these procedures in some patients. I just happen to think that it may be best used in more limited circumstances. So we'll get into that. A little bit of background though first, when it comes to ACL surgery in general, ACL reconstruction is far and away one of the best operations that has ever been invented. It's literally been refined over 130 years, and modern ACL reconstruction leading up until 2010 roughly had 90% good to excellent results and failure rates that were less than 5% across the board. The reason that we're having the debate that we're having now about adding LEAP procedures is that there were a series of studies that were published around 2010 that suggested slightly higher failure rates in some groups of patients. And indeed, those failure rates were higher than we'd like to see. And so that stirred a debate about what do we do about this? How do we do a better job for our patients? I'm going to back up a little bit more here, though, and suggest that when we're solving problems in any area of life, in professional existence, but definitely in medicine, the best way to solve any problem is to focus first on understanding it. Albert Einstein said that if he had an hour to solve a problem, he'd spend 55 minutes thinking about the problem first and 5 minutes thinking about solutions. And you see a lot of algorithms that are developed in business schools throughout the world of science and engineering, and particularly in medicine, that outline a very strategic, regimented, linear path for solving problems, where you first develop a problem statement, you then determine root causes, you rank those root causes, and then you vet them before actually coming up with a treatment recommendation. What you do not want to do is jump to a solution first, because in theory, ideally, you'd have a stepwise linear path to find the best solution, not just any solution, but the best solution. And in this case, the problem that we're dealing with here could be stated back in 2010 as ACL reconstruction has a higher failure rate in some patients. Ideally, what would have happened with this debate is that multiple different root causes would then have been identified and then studied. And some of those would have been shown to not be that significant. Others would have panned out as being more relevant. And then ranking them by importance, we would have devised ways to study them, first in a lab setting and then in clinical studies before making a treatment recommendation. Some of these would have actually been shown ineffective in both realms. Others might have been shown effective in the lab, but not in patients. And then finally, if we've gone through this whole process, ideally, we'd have found a treatment that worked in patients to solve the problem. And it's then that a treatment recommendation comes about. Not necessarily even a surgical recommendation, but a treatment that best solves the problem. What we want to avoid is skipping that process and jumping right to the solution. And this is what we call circular reasoning. Circular reasoning is a logical fallacy where an argument assumes the conclusion that it's trying to prove. It uses multiple unproven assumptions to reinforce its own narrative. And the problem with that is that it never actually solves the problem in the best way. It assumes the solution from the beginning. And particularly when it comes to surgery and treatment in the medical world, it can create a lot of turmoil in doing that. Now, there's a really famous circular reasoning example that's out there. I grew up in the Northeast, and so not far from Salem, Massachusetts, where the Salem witch trials occurred. And a little bit dramatic here, but I think to just get the effect, there was an event that started this off back in the 1690s. A group of children had fits, or they were described as fits, where they had convulsions and they started speaking strangely, throwing objects around. And at that time, the society basically figured out or rationalized what was happening with an assumption. And that assumption was witches are real and inherently evil. And then using a lot of circumstantial evidence, they made a second assumption that women at the fringes of society were witches. And then came the famous witch trials, which were basically trials designed to prove guilt. The third assumption that came after those trials is that if we condemn these witches, we'll improve what ails society. And then once convicted, the women had a choice: confess to being a witch or be hanged. And that reinforces the first assumption no matter what happens. So if you'd been alive in the 1690s, if you'd asked the question, why condemn these women? The answer would have been, obviously, because they're witches. Nobody bothered to ask if witches existed, if these women were in fact witches, and if executing them was actually going to make anybody better. But it was a process that reinforced itself. And you see this type of pattern a lot in medicine, a lot more than you might imagine. it's my contention that the argument for LEAP procedures is similarly circular. The event that began all this involved those series that we referenced. ACL failure rates were seen as higher in some new series. But instead of going through a systematic linear path to identify and understand why that was actually happening, treatment recommendations just started. And it started like this. The first assumption that was made is that ACL reconstruction can't stabilize the knee by itself. And then using some evidence I'll talk to you about in a second assumption was made that the anterolateral ligament is the missing link. It's the reason the knee is not stable with ACL tears. And then what I call the witch trials, a number of studies were subsequently designed and interpreted to fit that narrative. And you have a third assumption then that says LEAP procedures must decrease ACL failure rates, and you regurgitate the same data in multiple meta-analyses, which are basically just pooling the same studies over and over again, and it reinforces the first assumption. So if you ask the question now, why perform a LEAP procedure on everybody? The answer is because the ACL reconstruction is not good enough by itself. And this is a circular argument that feeds itself. So let's talk first about the evidence that the ALL or the anterolateral ligament is the missing link. So there are two arguments that you'll see out there that actually go back to around 2010. The first is what we call an extent of injury argument, essentially that ACL reconstructions are not working because there's this additional tissue injury that's not being addressed. And that comes from two areas. One is imaging data from MRIs that show that in the majority of ACL tears, the ALL or anterolateral ligament has some level of injury. And also from some open surgical data, which comes from two studies published from Italy, showing a high rate of some level of injury to the outer part of the knee. The problem with these studies is that they're what we call observational. They simply point out things that are not absolutely normal. They don't actually show that they're important. And if we actually look at clinical relevance, there are studies, in fact, that show that they're not. Anterolateral complex injury on MRI preoperatively actually has been shown not to correlate with instability in the operating room. And if ignored, it does not affect postoperative laxity. These are studies that don't get a lot of press because they don't fit the narrative, but in fact, there's really not a lot of evidence out there that the anterolateral ligament itself is that important. The second argument that we see is that the ACL needs support. That circular argument I mentioned to you that the ACL can't support itself, it needs protection, comes largely from a series of cadaveric studies that in fact do show if you cut pretty much everything on the lateral aspect of the knee, you see a lot more instability of the joint. That's definitely true. But if you look specifically at those studies, many of which are listed here, just at the anterolateral ligament part of it, which is what we reconstruct with these LEAP procedures, it actually appears to have a minimal role in most of the studies. And in knees that have the ACL cut, most studies show only a minimal effect. The biggest differences that are reported in the literature and get cited the most are typically in studies where a lot of other structures are cut as well, which is not something we see in typical knee injuries. If you look at what the reconstructions actually do here, we actually see that most studies show either no benefit. In fact, the ALL, when it does come into play, typically it comes into play only after the ACL has ceased to function, or there's an overconstraint effect. So either it tends to do not very much, or it overconstrains the knee. So in reality, if you really look in the weeds on these studies, the ALL probably has a minimal role in stabilizing the knee after most ACL injuries, not all, but probably most. And doing these reconstructions probably work by constraining the joint in a way that really only helps after the ACL has already failed. So these are not bodyguards to the ACL, they're backstops. Okay, so this second assumption that the ALL is the weak link, the missing link in the chain here. A lot of circumstantial evidence, at least I would argue, I don't know that that's proven. What about these other trials that are referenced? So when you really get down to brass tacks, what most people cite when it comes to arguing for these procedures is a series of clinical studies that are often combined in different combinations, which are what are called meta-analyses. And they do, in fact, conclude that doing a LEAP procedure better eliminates pivot shift, it reduces failure rates, has excellent outcome measures, no complications, exactly what Dr. Riboh mentioned to you. The first red flag here for me, though, is that if you look at all the different versions of these procedures, this is just a spattering of the different lateral extraarticular tenodesis or LET procedures and the anterolateral ligament reconstruction procedures. This is a dozen of them. There are quite a few more, actually. And if you look closely at these are all very different with very different tissue positions. They're tensioned differently and performed differently, but the literature would have us believe that they all do exactly the same thing. And that strains credibility to me. So there's a bit of a red flag there. On closer look, if you look at the clinical studies that really form the bedrock of the conclusions for this procedure, they essentially involve level 1 and 2 prospective randomized controlled trials, the type of studies that Dr. Riboh mentioned to you, which indeed they are the best designed studies that are out there. The other studies that tend to get more press are ones that don't fall into this particular design protocol. So these are the best studies that exist. And there are 15 of them in the English literature that are most often cited and regurgitated in different meta-analyses to prove the point. None of these studies actually demonstrate that the anterolateral complex has been injured before surgery. The control groups, so the groups that had ACL surgery in these studies, typically are high-risk groups that are predisposed to failure. And the definition of failure usually has a very broad definition, is pretty subjective. There's not a lot of, you can actually prove a failure with measuring something definable. And it's hard to blind these studies. In other words, if you have someone who's had an extra procedure on the outer part of the knee, for many of these studies, it was very difficult for the examiners to not know that that person had had the actual LEAP procedure versus the ACL alone. If we assume that those flaws are not there, though, no study is perfect. If we look at what they actually report on outcome measures, the vast majority actually show that no differences are present for the majority of patients. And when they're powered well, actually several of them favor doing just a simple ACL reconstruction. In fact, the Get Good paper, which is one of the more popular papers, Dr. Riboh mentioned it as well, actually showed higher early pain scores and a slower return to sport with the LEAP procedures. If you talk about re-tear rates, which is something that gets cited frequently, and you actually look at which of these studies have actually reported on re-tear rates, there are 8 of them. None of them were significant with the one exception of the Get Good paper. And the ACL patients in this group had soft tissue reconstructions with a lot of hyperlaxity, which is not a group of patients that would probably be a fair comparison for the majority of ACLs. That patient group would typically be treated with either a patellar tendon autograft or a different type of graft reconstruction. So it's a tough comparison, I think. If we assume for the sake of argument, though, that all of these numbers were significant, what we call the number needed to treat, which is the number of cases that would need to be performed to prevent one re-tear, using this data is 22. So that's 21 patients that would have had a LEAP procedure unnecessarily. If you look at stability, what we call pivot shift instability that's significant, 8 studies looked at this. None were significant except for one that came from China and used a very small diameter hamstring graft for the ACLs, which we know predisposes to failure as well. Here, the number needed to treat is 27. So 26 unnecessary surgeries for this, even if we assume that data is correct. If you take all of that together, this approach has questionable improvement in outcome measures. It might improve objective stability in some soft tissue reconstructions where you're possibly using a graft that would not be ideal. But the number needed to treat approaches 30 patients. And the question that vexes me a little bit with this whole debate is it justified for widespread use? There definitely are situations in high-risk patients, and Dr. Riboh's practice is very, very high risk. He is an expert in adolescent ACL reconstruction. And the majority of those patients, you do not have the luxury of using adult grafts, and you definitely are dealing with higher risk patients. But for everybody out there, it's questionable to me whether the data actually supports doing this. Yet you see that these meta-analyses that are done take the data that really pushes the narrative, and they keep republishing it. And you have recommendations like this published in one of our more respected journals in 2021, saying that this should pretty much be done in everybody. To me, that fits an unproven assumption in this circular reasoning. But if you look at that first original assumption now, and you say, okay, Piasecki, so what about this ACL reconstruction can't stand by itself? Like, if that's true, then why aren't we supporting this kind of a concept? If we look at this absence of the systematic linear approach, What about root causes? Are there other potential explanations that would better explain the higher failure rates that we're seeing around 2010? The problem with circular reasoning, of course, it doesn't consider those causes. And in fact, we've known for the last 125 years that the leading avoidable cause of failure of ACL surgery are technical issues related to where the graft is positioned on the femur bone on one side of the joint. Any useful assessment of ACL graft failure, even if it's not related to that the actual cause of failure exists, it has to account for that factor. But none of the biomechanical or clinical studies that are cited to promote LEAP procedures accounts for femoral tunnel characteristics. None. In fact, what happened around the early 2000s and into 2010, exactly at the time we started to see higher failure rates, is that we did, as a community of surgeons, actually change the femoral tunnel. These images on the right are cadaveric specimens of a human knee, and we took a tunnel that was like this, and we moved it to something like this. And we know that that change in position from multiple finite element analysis studies that look at graft strain show much higher graft forces doing that. So this is a study we published 3 years ago looking at graft strain based on aperture and tunnel orientation variables. And on the left, the blue cylinder is a graft from most of the ACLs that would have been done before 2005. And on the right, most of the grafts after 2005. That increased color is the amount of graft strain that is seen by the ACL. And we know based on that the grafts after 2005, again, right around the time we saw these higher failure rates, were subjected to much higher forces. The second thing that we really have not paid attention to enough, I think, is rehab after ACL surgery. So the ACL protocols that are largely used today are the same protocols that were used in the 1990s, and yet rehab was not adapted. Those rehab protocols were adapted for the graft positions that did not see a lot of force, and yet we're subjecting these new ACL positions, these new grafts, to higher forces without changing the rehab. And the last thing that really hasn't been looked at effectively enough, there is data coming out of Canada soon enough. I believe the Stability 2 trial will come out relatively soon, looking at different grafts, but we know that hamstring grafts, soft tissue grafts, have higher failure rates in some patients. 95% of the studies that are used to support LEAP procedures use hamstring grafts and not patellar tendon grafts, which are known to have a lower failure rate. So the answer here, in my view at least, is that this original assumption, by not accounting for other, probably more likely explanations for the higher failure rates, is unproven. But in my view, this argument, it's even worse, because this has been tried before, actually. If you go back to the 1980s, the addition of an extraarticular portion of reconstruction to an ACL graft was actually already looked at and found to be unnecessary. This procedure, which is shown in this black and white drawing, the Zahren's-Rowe procedure, very common in the mid-80s, involving an extra limb of graft to reconstruct essentially the anterolateral ligament. Authors looked at this back in the 80s and the 90s and found that these reconstructions did one of two things. Either they increased stiffness or constrained the knee, or they didn't do much of anything at all. That sounds a lot like the biomechanical studies that we're seeing now from the LEAP procedures. And my challenge to those that perform these procedures routinely is, I think you need to be able to explain why what's on the left, which was abandoned, the Zahren's-Rowe procedure from the mid-80s, is that much different than what's being championed right now on the right, which is Sonnery-Cattay's procedure. So in summary, the argument for LEAP, in my view at least, it's circular, and it fails to prove its own self-reinforcing assumptions. Generalized use, not limited use. There are situations where limited use I think is appropriate, but generalized use probably involves unnecessary surgery for the majority of patients. And in my view, at least, the vast majority of patients will do best with a well-done, isolated ACL reconstruction. That's Dr. Riboh as a witch.
That's right.
All right, so this is a time for you guys to ask questions. So send your questions into the comments, and we'll do our best to answer them for you.
So the first question we have here is, what does recovery look like for each of these surgeries? Great question. I'd say first of all, this is surgeon specific. So I think we all have
Totally.
our ways that we like to rehab things. I will tell you in my practice, whether I add a lateral procedure or not, it's actually the exact same rehab. So it doesn't impose more crutch use, more brace use, any restrictions in weight bearing. I will say it probably just requires a little bit more diligence between the physical therapist and the patient to mitigate any risk of stiffness. And so I just tell people, if you're going to consider this procedure, because we deem that you're at high risk of re-injury, this just means you're going to have to work a little bit harder in physical therapy to avoid any stiffness. I don't know, what's your experience?
No, same. So when I do, I mean, again, I don't want to send the message I never do these procedures. I do think there's a middle ground here. When I do these procedures in the select patients where I think it's appropriate, it is the same recovery. I find it does take longer, at least in my hands. I've seen the recovery through PT and return to play. It does take a little longer to get back the motion, strength, coordination elements that we want to really refine at the very end of return to play. But the principles and the basic milestones are the same.
This is a great one. How does age affect the outcomes of these surgeries? Well, so this is really important in my world. So again, I treat, about 150 patients a year with ACL tears. Probably 130 of those are under the age of 18. And many of them are as young as 8, 9, 10 years old. And so I see a skewed population, and I recognize that. But the numbers are sobering, and that kind of child or young adult population that I see, the failure rates are above 20% with an isolated ACL surgery. And that's been shown at probably half a dozen of the big pediatric hospitals around the country. So those aren't just my results, that's sort of across the country. And so to me, actually, the biggest driver of deciding who to do this on is actually age. And I think that's not just because they're young, but it's also because your age correlates with what you're going to do afterwards. Right? If I tore my ACL skiing, I would probably decide not to ski again because the risk might not be worth it. But if you're 15 and you tear your ACL playing basketball, your first question is, when can I play basketball again? And so your exposure to risk is higher as a kid. So how does age affect the outcomes? To me, younger age very clearly, both in my experience and literature, portends a higher risk of failure with any ACL surgery, but particularly an isolated ACL surgery. And so that's going to push me towards considering these lateral procedures, which we can actually do safely at any age.
I totally agree with that. I think age definitely has an impact, and that would be, in my world, the LET or the ALL approach, the LEAP procedure, would be almost only in extremely young patients that have a super high risk of re-tear, where we can't use a stronger graft. We have to use a graft that would have historically a worse failure rate. But understanding what it's doing, it's constraining the knee, at least in my view, it's constraining the knee artificially in an effort to try to create a little bit of an extra burden for instability. But I don't know that I think it's actually protecting the graft, but it is probably slowing down the knee in general in a way that appears to decrease failure rates in that very select high risk group.
You want to take this one first?
Sure.
I don't want to steal all the thunder.
So if I tore my ACL in 2005 and never had surgery, will I need surgery in the future? That really depends. I think that's the answer my kids get on me all the time, because the answer is always, it depends. It probably depends on how active you are now and whether you're having symptoms now. The main issues that we see with not having an ACL in the first place, just to back up a little bit, it's function. So the ACL is important for keeping the knee from being too unstable. Usually when you're doing twisting activities where you do cutting, pivoting, things like skiing, soccer, basketball, that kind of thing. And so if you don't have it, you often will have issues doing those types of activities in life. So that's a quality of life issue. The second issue that we often will see is that if you are active and you don't have an ACL and your knee is being unstable in the course of living an active lifestyle, that you'll often have other collateral damage. So you'll have meniscus tears, potentially issues with the cartilage, other ligaments can sometimes be injured. There are people out there who tear the ACL and do perfectly well without doing anything. I think it really depends on if you're seeing issues with function and with health. And you could tell about the health part of it if you're having a lot of pain, swelling with activities, if the knee's giving out all the time. So will you need surgery in the future? If you're super active, statistically, we do tend to see more problems with the knee in terms of that quality of life and potentially other things being damaged. That doesn't necessarily mean it's going to lead to surgery, but if you're not having symptoms at this point, my guess is you're going to do great. But hard to say for sure without being able to, see a face-to-face, examine your knee and know the details, but I think it does depend. Anything to add there?
No, not really. I mean, I think something you touched on a little bit, but just to say out loud is that whenever you tear your ACL, your knee is at a heightened risk of developing arthritis later in life. And interestingly, even when we fix the ACL, it doesn't seem to change that risk all that much, where the numbers would suggest that at 10 years after an ACL injury, 70% of patients will have at least X-ray evidence of arthritis. And so depending on how far in the future this question is alluding to, actually that risk probably goes up, where a lot of the patients who end up getting knee replacements in their 60s or 70s often had a history of a ligament injury back when they were young. Let's see, what long-term outcomes have you personally seen in patients who undergo an ALL LAT? Well, I can answer this pretty specifically because we're studying this right now here at OrthoCarolina. So we are in the process of collecting data for a study, at least on patients that I've treated. And I looked at the first 150 combined ACL LAT surgeries that I did. While the data is not fully finalized yet, we're still making sure we have all our T's crossed and our I's dotted. To my knowledge, none of them have retorn. And that's in a very high risk cohort with the mean age probably of 15 to 16 years. And so is that long-term outcome? These are minimum 2-year, somewhere between 2 and 5 year outcomes. So not necessarily long-term and medium-term, but my experience has been exceptionally low failure rates, which is great. A slight stiffness rate. I probably have 1 or 2 people a year that I have to take back to the operating room, again, for a 10 to 15 minute procedure to remove scar tissue, which then solves the issue. But this has been a very, very positive aspect of my practice, because my worst day at the office is when I have to tell a kid that they tore their ACL graft that I had performed. And the less I can do that, the happier I'm going to be. And so adding these lateral procedures to my practice certainly has achieved that. See, Dr. Riboh, how long have you been conducting research for this return to play research? Can you give a brief explanation of what it is? Yep. So, well, I've been at OrthoCarolina for 5 years now. I came here after practicing in a university setting elsewhere in the state, and started a return to play initiative essentially when I got here. So I guess it's been 5 years. What does that look like? Well, this really came from our group coming together and saying, let's focus our research on what really matters to our patients. And I think we'd all agree the number one thing that people want is they want to get back to playing. Now, that might be playing golf after a reverse shoulder replacement. It might be playing soccer after an ACL. It can be a whole variety of things. But broadly, the ability to take an athlete who's hurt or an individual that's hurt and return them to the activities or sports that they want to do is all of our goals here at OrthoCarolina. So we now have numbers of studies going on, not just in the ACL world, but in the shoulder instability world, even in the shoulder replacement world, to understand how do we best get people back? How do we do it safer? How do we do it better? How do we do it faster? This is collaborative research with our physical therapy colleagues, as well as our surgical colleagues, trying to get at these answers. I'll let you take this one. I know how I feel.
So, okay, this is a great question. Which surgery would you recommend if a patient re-injured their knee and needs another ACL reconstruction? So what you're talking about there is redoing an ACL. These are some of the most challenging cases that we see there. As Dr. Riboh suggested, it's brutal for the athlete. It's very difficult for the family. It's a challenging technical question with a lot of different facets to it for the surgeons. There's not one size fits all here. There are a lot of factors that go into deciding which surgery is the best option. Really what we're trying to do ultimately, though, is to get back to something as close as possible to what the patient had before they injured it the first time. That's truthfully not ever 100,000% possible. We can't ever return the knee to 100% normal. But we do pay attention to factors. For instance, why perhaps did the ACL, the first surgery, not work? And as I suggested in my comments, most of the time, if there's a technical issue, it's not always a technical issue. Often the surgery is done perfectly well. Everything was done great. The patient did all the rehab they're supposed to do, and then he just had bad luck. I mean, you can re-tear an ACL graft the way you tear your original ligament. But we're looking for things. How can we change this on a second time through to prevent it from happening again? And so factors related to graft choice, tunnel position especially, the femoral tunnel, as I mentioned, is the most common site of technical issues related to the ACL not working on the front end. Other ligaments that may have been involved, we know that if there's looseness elsewhere in the knee or problems, as Dr. Riboh alluded to with the meniscus and other factors that may impact stability, we want to make sure we correct those. And then we do pay attention to things like the outer restraints of the knee. I think for me, my approach to revision ACL surgery, it's a patient-specific approach. We try to optimize the graft choice with using the patient's tissue, making the tunnel positions perfect, dealing with all the other issues that could have contributed to the failure in the first place. And that includes post-operative rehab, being really careful about how we return patients to play. We know that how the neuromuscular characteristics of the knee function after you recover from an ACL have a huge impact on whether or not another injury occurs. So we try to take all those things into account to get a tailored approach for the patient. With respect to the LEAP procedure, this is one of the narrow indications for me where I'll consider it. If a patient has had a failed ACL, usually for me it's multiple failures, because usually we can identify factors that we think we can do a better job on the second time through, sometimes even the third time through. If we're getting into like they've had 3 or 4 ACLs and we're not identifying, it's clear that the surgeons that have treated them before have done a really good job trying to figure out the problems and are addressing it, and we do not have a clear explanation for why it didn't work, then adding in one of these non-anatomic restraints, an LET or an anterolateral ligament reconstruction of some kind, I do think it has merit. What you're sort of saying in that situation is we're going to give it everything we have to prevent it from tearing again. And so that would be the way I'd approach it. I don't know if you have anything to add there.
No, I mean, I think I would summarize my approach to the revision as fix what's broken. Meaning you will only achieve a stable knee if you fix the elements that are not right. And many times in a revision, that's a meniscus injury. It could be a missed collateral ligament injury. So you have to fix the things that are broken. Where I think these lateral procedures come into play is when you have an ACL that was well done. Like if one of Dr. Piasecki's patients somehow made their way into my office after they tore their ACL, I know he did a great job the first time. I know his femoral tunnel position was good. And they're more in the bad luck category. Like I can't blame any technical or anatomic factor as to why it happened. That's when I really think the lateral procedures can help, because then it's reducing our risk because I don't have any other tricks up my sleeve. This is a good question. So the question is, if I have a minor ACL tear, how can I treat it without invasive procedures? I think the important thing to understand about ACL tears is that how they look on an MRI might not actually matter so much. So these radiologists will grade these, as they should, with, it's a low grade partial, maybe what you're referring to as a grade 1 tear, or maybe it's a high grade partial, but really fundamentally what matters is your knee stable or is it not? And that is actually a clinical physical examination finding as well as a historical finding. And so if I have a patient who has a somewhat subtle abnormality on their MRI of their ACL, but the patient in no other words tells me my knee is unstable, I trust the patient always over the MRI. Same thing, if I examine their knee and they are flagrantly unstable, but the MRI says it's partial, it doesn't so much matter, right? So what matters is your physical exam and your history. So I would say, how can I treat a minor ACL tear without invasive procedure? I'd say you could achieve that if you're not having symptoms of instability. and if your physical examination does not indicate that there's objective instability. In that case, there are actually very well established physical therapy protocols that can help strengthen the muscles around the knee to allow you to accommodate for maybe a small amount of instability. There are braces that exist in many shapes and forms that have been shown to be beneficial for people in the non-surgical treatment of ACLs. And so I think a combination of bracing, good rehabilitation, and the correct indication for non-operative treatment is how you would be successful.
Yeah, I would just add I completely agree. I would add just two little caveats there. One is I definitely agree with don't overinterpret the MRI. It's super common to see an abnormality on an MRI that is just not important. You don't have to worry about it. And the other feature has to do with function and how you're performing. The muscles around the knee are absolutely miraculous in the way that they balance the forces in the knee. And so just hitting on what Dr. Riboh said about physical therapy protocols, a lot of times what we see is instability that you feel in your knee. It may not actually be related to a ligament. It very commonly is related to muscle imbalance, particularly quad weakness. And many patients that have an MRI that shows what is read as a partial ACL tear, it may be a total red herring. It has nothing to do with what they're actually feeling. And in fact, what you may be feeling is just a little bit of muscle imbalance that physical therapy can make better. Different versions of therapy, some of which are very high performance, jumping, cutting, pivoting, agility testing. Different versions of that, though, can make a big difference in that. So I totally agree. You don't want to treat the MRI. You want to make sure that it's actually a significant finding. And most partial ACL tears, the ones that are real partial tears, we can figure out with a patient if it's significant. You have to worry about it or not.
Patients drive or come from ACL surgery and when? Okay, so
well, I wonder what your answer is for this.
Okay, well, so part of this is interesting. This is actually a disclaimer. I'm not an attorney, and this actually sort of comes into sort of some legal stuff. But certainly, you can drive during some portion of your ACL recovery. You know, total recovery from an ACL is upwards of 9 months, and so certainly you're not gonna be out of driving for 9 months. What I tell people is that there are some legal implications. So you cannot drive while impaired, and meaning you have to be strong enough to safely drive the car, safely slam on the brakes, safely avoid another vehicle for your own safety and the safety of the public. My criteria for when somebody can drive, if it is their right knee, because that is sort of the one you don't want to tear if you want to drive quickly. If it is your right knee, to me, you have to be able to do 10 straight leg raises in a row, showing me that your quad is strong. You have to be pain-free, and you have to be off of any prescription pain medication. I'd say for the average patient, depending on what we do, that's probably in the 2 to 4 week range after surgery. So I don't put a hard number on when you can drive. It's really more driven by when you can meet these physical parameters that allow for safety. Another important consideration is that bracing matters. So if you are in a brace, if you are driving with a brace on in North Carolina, that is considered driving while impaired. So you do not want to drive while you're in a brace. And so depending on what operation you had, that might lengthen the period of time that you cannot be driving. Probably at the latest, though, it would be 6 weeks. That might be the latest that someone would have to be out of driving.
It depends a little bit for me. I agree with all that. Depends a little bit for me in terms of whether you're weight bearing or not, because it's rare, but most ACL surgeries, if it's just the ACL and not a crazy meniscus tear, usually you can put as much weight down as you want right away. What we found is that this comes from actually the ankle fracture literature in the foot and ankle world. Reaction time largely is correlated with whether you're limping or not. As soon as you can walk without a limp, assuming it's okay to put weight down, then your reaction time likely is okay. And that usually is right around that 2 week mark, roughly. It depends a little bit on the patient. I agree with the brace. It depends on how strict the brace use is, though, to meet that criteria. Like you definitely do not want to drive in a brace. That's bad for a lot of reasons. But many ACL surgeries, we use bracing to protect you when you're weight bearing and at night to get your extension, your straightening back. But at other times you don't need it. So if you're walking without a limp, but technically you're still in a phase where the brace is part of your treatment, you can safely take the brace off but put it in your back seat and then drive in that situation. But the bottom line is you do want to be safe. I have some patients who are like, look, I'm not limping, but I still don't feel comfortable. And the answer is always don't drive in that situation. But for most patients after these surgeries, you're usually able to get yourself around in a couple of weeks.
All righty, what role do patient lifestyle and activity goals play in deciding the best treatment? A huge role, probably the most important role. Obviously, the decision to undergo ACL surgery is, in Dr. Piasecki's words, it's a huge decision. You know, it's 60 to 90 minutes out of our lives, but it's 9 to 12 months out of the patient's lives that they are committing if they do this operation to physical therapy several times a week, you know, a lot of effort, a lot of sort of blood, sweat, and tears to achieve the final outcome. And so you have to make sure that you're doing the operation for the right reason. And the reasons are to protect your knee from further injury, but also to allow you to achieve the lifestyle and activity goals that you have. So for me, this comes into play a lot in, I don't want to use the word old, but say older than my sort of standard patient. Let's take somebody who's in our age category, right? We're still both very active, but if Dr. Piasecki came in as a patient and he had torn his ACL, I would ask him, well, what do you want to be doing when it's all said and done? Mm-hmm. If he says that he wants to be doing martial arts and he wants to go elk hunting in Alaska and he wants to be skydiving and doing a variety of things, then I would say you probably need an ACL reconstruction. If he said that he plays a lot of mahjong and that he also likes—
Nothing against mahjong.
Right. And that he enjoys long walks on the beach, he might not actually need a functioning ACL, and it might not be worth the time off of work and everything. So really tailoring the surgery to the patient is critically important.
Yeah, I totally agree. I just second what we said before, which is the purpose of the ACL is function of your knee and health of your knee. So if you're at a point in life where you may already have some arthritis and you're not that active, there's zero reason to have the surgery. If you're younger, more active, it makes a lot of sense. But these are the factors that we're always trying to discern and weigh when we talk to patients about the risks and benefits of doing surgery. All right. Thank you all for attending. I think we're out of time here. Just a reminder, a replay of this will end up on all our social media platforms. And just thank you for paying attention. Have a great night.
Have a great night.